Welcome back to the podcast, Dr. Roshani. And I'm going to start this episode with the burning question of why the low carb approach is becoming so non-negotiable for Indians. It's estimated that around 77 million adults in India are living with diabetes, and about 25 million have prediabetes. Myth about fatty liver being seen only in overweight individuals. I'm also seeing that in underweight individuals.
About how the calories in, calories out model has completely failed. They monitored people's glucose profiles and they saw that the glucose spikes were less when you started with the protein or the veg and kept the carbs last. And so Dr. Bernstein came up with this concept of the law of small numbers. You can achieve the normal glucose levels for the mother and baby.
Lipid profile gets better, sleep gets better, exercise performance gets better,
Skin gets
better. Hi everyone, this is Shwetha, Bhatia, registered dietitian and sports nutritionist. Today, I'm truly delighted to welcome back someone really special, Dr. Roshani Sanghani. She's been on my podcast before. Dr. Roshani has 16 years of experience and is a US board-certified endocrinologist and an accredited practitioner with the Society of Metabolic Health Practitioners. She focuses a lot on de-prescription. She's been championing a low-carb lifestyle that she blends beautifully with medicine. She contributes meaningful content on leading platforms, and it's truly a pleasure to host her again. In today's episode, we are going to be discussing a very tough but important topic: why low carbohydrate diets are non-negotiable for Indians. We're also going to discuss new insights on diabetes, insulin resistance, childhood obesity, and PCOS. So let's dive in. Welcome back to the podcast, Dr. Roshani. It's such a pleasure talking to you always because, we align so well. You are such a strong advocate of the low carb way of life. And I'm going to start this episode with the burning question of why the low carb approach is becoming so non-negotiable for Indians. I'm just going to, throw some data out there so that there's more relevance to our conversation. It's estimated that around 77 million adults in India are living with diabetes, and about 25 million have prediabetes. And if we look at the overweight stats amongst children, children who are in the age group of 5 to 19 years, which includes adolescents, we have around 12.5 million of them living with severe overweight and obesity, right? And it's estimated that by 2030, about 27 million children in India are going to be overweight and obese, which contributes to almost 11% of the global numbers. That's very alarming, and I don't want to stop there. I actually want to go one step ahead and talk about very young children because I see that in clinic. And the data for children who are under 5 years of age, the obesity rates are increasing by 127%, over the last 14 years. The data, we're looking at 2005 to 2019. So yeah, over to you. I want to hear from you now.
Yeah, India is a very complex country, and thanks for having me on. It's a burning, sobering question we're starting with, but and it's important to talk about this. But India is a very complex country. On one hand, we've been dealing with infant mortality and malnutrition, and maybe from there now we've come into this place where a chubby baby is a healthy baby or a well baby, so that they're not undernourished, and maybe we've overcompensated,
right?
And we're overfeeding our little ones, and they're heading into metabolic disease right from an early age.
Right.
I work with some pediatricians who are telling me the stats are very alarming across the country. 1 in 3 kids with fatty liver, 1 in 5 kids heading to prediabetes, high triglycerides in young children. Before they even take a start on life, they're getting sick.
Well, while we're talking about fatty liver, I think I want to just break this one myth about, fatty liver being seen only in overweight individuals. I'm also seeing that in underweight individuals now. And we have this concept of the normal weight obese, where somebody might be, in line with their weight for their height, but they have fatty liver, they have a protruding belly, or they're showing signs of insulin resistance. So it's so important for us to start this process very early on. And as you rightly said, because if we are seeing this syndrome in children, we're setting them up for future complications of heart disease and diabetes as they grow older.
Absolutely. India is taking the lead on young people in their 30s and 40s. We all are hearing about it in our corporate offices, in gyms is where it gets in the news.
Right.
But that's a sad sort of distortion in the media. But the truth is that young people are getting sicker, and we need to catch this early.
I'm going to add one interesting point here. My research topic is insulin resistance in professional Indian athletes. The reason why I chose that topic is because I work so closely with athletes, and I'm seeing that the traditional sports nutrition principles of loading carbohydrates just because you're physically active no longer holds for especially Indians, because now we see high fasting sugar, we see high fasting insulin, we are seeing high visceral fat on their DEXAs, and most of them are coming to me for losing weight. So this whole idea of exercise being able to offset a bad diet just no longer holds true, and it's being proven now even in very, very highly active individuals.
Absolutely. So I think you mentioned 2 points. One is the athlete and one is the lean individual. Maybe they're not into sports, they're just regular lay people. But what we should talk about is how you mentioned burning off the calories, right? Or that if they're burning so many calories, it should be okay to eat whatever, or to fuel the exercise, they're loading with carbs. And the lay person who thinks, I'm just eating home food, low calorie, light food. And I think we should spend a minute here, because I'm a hormone doctor, is to talk about how the calories in, calories out model has completely failed.
Correct.
And in India, more so, we have to be very careful about the hormone insulin rather than calories. You might be calorie malnourished also. And unfortunately, since we have such a diverse country, we must talk about low income groups. If we try to do food drives or donation drives, what do they get? They get bags of rice and biscuits, non-perishables. So they're being given carbohydrates. This is now spiking the insulin. So whether you take the low socioeconomic or you take the very wealthy, we have a very predominant carbohydrate predominant diet. Even athletes that you see, carbohydrate predominance drives the hormone insulin. And diabetes is not just about high glucose, it's also high insulin. And that's many steps before diabetes is the fatty liver, the triglycerides, thin fat. So you could be very skinny and have high insulin levels.
I'm going to just add another point here because we were talking about nutrition and the calorie concept that is so prevalent in our country right now, where anybody can go on the internet, grab an equation and figure out how many calories they want. But it's so important that we identify what makes up those calories on our plate. For example, like you rightly said, you can be in a calorie deficit, but if from those calories, a large part of it is coming from carbohydrates, you may end up losing weight, but you may not end up losing fat.
Yes, so we can talk about the concept of sarcopenia and muscle losses. So you could be malnourished, thin, and in the adults, sometimes I'm Gujarati, and so a lot of people will say they're so thin on the arms and legs, they're so weak. Right. How can you have them lose more weight? And this concert happens a lot, is the family members are protesting that if you make the 2 chapati to 1, this person's going to become more weak.
Right.
And we seem to associate carbs for energy. So this is a wrong messaging that carbohydrates are energy giving foods. You don't need to eat carbs for energy. And the weakness that they're talking about, they're translating from the weighing scale, but we need to talk about weakness and strength in terms of muscle.
I remember one line that you mentioned in my last podcast, that I prescribe or I advise a low carbohydrate diet to everybody who has 2 hands and 2 feet.
Yes, I say it in different ways every time, but that's exactly true.
I would have more clients if I had promoted the eat all you want in moderation concept in my practice. And that brings me to the next part about how difficult it is for Indians to adopt a low carb way of living, because everybody thinks about sustainability. Will I be able to do it? So 3 things in this which I want to talk about, because I see this in practice. Number 1 is misinformation. A lot of Indians are following the carb way of living is because, number 1, they think it's an important essential nutrient, because without which we can't have energy. Number 2 is lack of information on the sources, because a lot of people again think that, oh, I've stopped eating wheat, now I'm eating jawar, but they're still eating carbohydrates. The third point is about the accessibility. So even for me, someone who's been following a low carb way of living since the last 20 years now, if I had to walk into a cafe and I'm really hungry, there's nothing for me to order except a black coffee. So we just don't get those food options. And I understand how difficult it becomes in a country like ours. And then in a family setting, everybody else is eating it, but we have to stay away from it. So that becomes difficult. And lastly, the addictive nature, because we have seen relapses where people have done the low carb diets, they have gotten results, and then suddenly they start slipping off because you're getting exposed to these foods and you know how addictive glucose can be. So over to you.
Yeah, so a lot to respond to there, but let's go first with the misinformation about carbohydrates being the energy giving foods. It is true that if you take carbs, they will give you instant energy. The way if you throw a piece of paper into a bonfire, you'll have a blast of the flames,
Right.
but it dies down again. So you have this energy crash. And that's what people don't realize, that the need to eat every few hours is coming from that person who has started their day with carbohydrates, which is a short-term energy, and you're constantly needing that top up through the day.
Right.
The other thing you said about culture, I agree. Sometimes the way I hear it in a patient is, oh, if the vegetable is very tasty, then I'll have more rice or more roti. So I'm like, no, wait, if the vegetable is tasty, you would have more vegetable, but the roti and the rice becomes the spoon.
Right.
Okay. So we seem to use the carbs to, I think because we eat so much spice, that we use the carbs to dilute the heat and enjoy the flavor with that balance and that mouthfeel. So that's another barrier sometimes when you're working with a kitchen or a family to deal with this. And that attachment to, oh, but my tradition and, my
Right.
home recipes. And there's nothing, again, I'm Gujarati, I love my Gujarati food. It's about helping people realize their relationship with their food. And like the question of sustainability, what is the alternative? You could keep eating this way, but look around you at the stats that you mentioned. Look at how sick our country is becoming. And a lot of this comes from home food, from home traditions. So I don't eat like a typical Gujarati anymore because I've touched pre-diabetes and come back. And for me, that trade-off is not worth it.
Well said. And I'm a Mangalorean, so I have very strong rice eating roots. I have given carbs off. It wasn't difficult. I mean, it wasn't easy for me either, but I still advocate the low carb way of living because I know that it really works and it is the need of the hour. Coming back to this whole point about the addictive nature, right? And you just said that we end up eating a lot more roti and rice because the vegetable is tasty. But where's the protein?
Yes.
Right? And when we talk about mindful eating, I know that there are a lot of professionals who talk about, you have to exercise control and portion control. But the point is that the food itself, by nature, is so addictive. You can't exercise portion control with it.
Yes.
Right? So there is a need to either we redo the sequence of the foods that we eat on our plate, and we should also realize the importance of the gut-brain signaling, where certain nutrients, like say for example protein, can make you full faster. Therefore, it should come first in sequence, and then maybe we have the carbs follow, right behind it.
Agree. So a couple of hormonal explanations for that is the satiety concept, the feeling full that comes is not from carbs. Carbs don't make you feel full.
Correct.
Which is why we always know the phrase is there's always room for dessert.
Right.
If I come to you at the end of the meal with a bowl of dal or a piece of chicken or meat, you're going to say, I'm full. I can't eat that. I know it's very filling to eat more protein. So yes, food sequencing, and actually there's an endocrinologist of Indian origin who's published a study on this, looking at the sequence of protein or veg and then carb, or veg and then protein and last carb, versus starting with the carb.
Right.
And they monitored people's glucose profiles, and they saw that the glucose spikes were less when you started with the protein or the veg and kept the carbs last. The other hormonal thing we should talk about is when you have a high carb load, you have high insulin response because we don't want this high carb to turn into glucose. So your insulin is trying to keep the normal glucose. So you have high insulin. High insulin causes leptin resistance.
Right.
Leptin is the hormone that says to the brain, I'm full, you may stop eating. So if you don't have that, you're feeling, I'm hungry, I want to keep eating. And because the news is so full of this GLP-1 medication, I should say that I just came across research that says eating protein in the diet increases your natural GLP-1 levels.
Wow.
But without all the side effects that we're reading about in the GLP-1 medication.
Interesting. And I'm going to add one more point here. I came across a very interesting research where they said that all these hacks that you see on the internet about eat your protein first to reduce the glucose spikes doesn't really work the way it's shown for insulin resistance individuals.
Absolutely.
So we can't use that method to blunt the glucose or the insulin spike in individuals who are already insulin resistant.
Yes, so it's a two-pronged approach. I have a biased population. I see people all with insulin resistance from day one. Now they're hungry all the time. And that's part of the thing, is that even when I increase the protein, they're still feeling hungry.
Right.
So we have to work with a couple of things. Check if they're eating with distraction, like you said, mindful eating, right. Slow it down, take a halfway checkpoint, add the protein and the healthy fats. And luckily, we've been able to sort of, and you see it in your practice too, is you're able to sort of make that gradual switch where fullness, and I have a problem now where everybody's like, I'm so full, you're giving me so much protein, I can't eat.
It's the same problem I have. I don't think it's a problem. It's a good
It's
thing.
a good problem.
But that good problem always happens in the first week itself of the diet, when it starts. So that's amazing.
Yeah, like would you rather be hungry all day or full all day?
And then we don't really need the willpower.
Yes, you don't need the willpower. You might not need the GLP-1s.
Correct. Talking about young children, and we're looking at the rates of obesity and overweight in young children. I'm seeing this alarming trend of a high fasting insulin and fatty liver in young children. In fact, that you and I were discussing this case a few days ago, where this 17-year-old boy was on metformin or rather has been on metformin for the last 5 years. But his labs in terms of the A1C and the glucose is normal, but we see a high fasting insulin of 25 and fatty liver on the sonography. So what is your take on this? Can we also advocate or rather promote a low carb approach for children in this category?
100%. And it's a sad state of affairs. And I kind of take responsibility as a physician that we as doctors, unfortunately, have become trained to give a pill for every ill, and we have become very glucose focused. Endocrinologists are diabetes experts, and so they feel that a child with obesity should be given metformin. It's not really a weight loss pill. It helps address insulin resistance,
Right.
but it doesn't cure anything. It doesn't cure the cause of the insulin resistance. Now, unfortunately, the family or the patient or the doctor might be looking, oh, normal blood glucose, normal HbA1c, no diabetes, nothing to worry, keep taking the pill. But you've picked up warning signs. You're seeing a high insulin, you're seeing fatty liver. This child's body is working overtime to prevent diabetes, but the insulin and the liver are already falling in trouble. The pancreas and the liver, they're already struggling to keep things in balance. And this child is on their way to developing all the complications of insulin resistance. So we need to help them get to the root of that.
So am I right when I say that the low carb approach applies for this category as well?
100%. You would be able to do what metformin could not do. And I could quote a study that was published in 2002 in the New England Journal of Medicine, taking people of pre-diabetes background and giving them either lifestyle change or metformin or routine care. And the lifestyle group prevented more cases of diabetes than the metformin group. So we've had at least 20 years of proof now, but it doesn't get the news, it doesn't catch headlines.
Sure.
That lifestyle change is more powerful even than metformin.
And there is a requirement for us to address the warning signs, the early signs, especially in children, so that we can prevent diabetes and pre-diabetes, which is tackling the insulin resistance and at the fatty liver stage, right? That brings me to my next question about the window for reversing these conditions. So we see that on the internet, there are a lot of programs and a lot of healthcare professionals promote reversal of diabetes. But I really want you to speak about, as a medical professional, what is that window or what is this category of individuals who can reverse diabetes, and is there something called as remission and reversal, and what's the difference?
Yeah, so I spent some time on this in my book, and I thought a lot about what the title should be.
Right.
And I ended up on the word turnaround diabetes, meaning to say if you're headed all the way downhill where it's one medicine, two medicine, finally insulin and more doses of insulin.
Right.
Let's turn that journey around. Let's take a different turn where you don't have to have this worsening health. Now, the word reversal, I used to use it about 10 years ago. I was using that word as well. We realized that maybe that's not the right way. We don't want to give people false directionality or they just stop thinking about it, saying it's gone.
Right.
It's kind of like maybe you could call it a chronic state or a tendency like a cancer, for example,
Yes.
where we say this person's cancer is now in remission. So we're going to keep an eye on it. We're going to make sure it doesn't come back. Right. So remission might be the better word, type 2 diabetes remission. How would I know? And it's not about how many years. Sometimes the sad assumption, and I made this assumption about a decade ago, my eyes opened to this wrong thinking, was if tablets are not working, like let's take your young boy, right, who was on metformin. Someone might say when he finally develops pre-diabetes or diabetes, tablets didn't work.
Yeah.
And they'll say, let's add 2, 3, 4 tablets. I had such a gentleman who was on 4 tablets for diabetes, not working, and he was supposed to be given insulin now as the treatment protocol. The mistake in that logic is we assume that this person's pancreas is now burnt out, it's the end of the road, and now they have to go on insulin.
Okay.
So it doesn't matter how many years you've had diabetes, The way to know whether your pancreas is still making natural insulin or not is a fasting C-peptide test.
Right.
That's a very specific test. Most diabetes packages don't do it. You need to ask for a C-peptide test. If your pancreas is making insulin, why would I give you insulin?
Right.
Insulin therapy is only meant for when the pancreas is not doing that. We call it type 1 diabetes, and you would need insulin to stay alive. But for everybody else, I've done this with people who've been on 30 years of diabetes, 5 years of insulin therapy. We confirm the C-peptide. We're able to focus on the lifestyle changes and get these people off insulin within days to weeks.
Amazing. And I think I would also add something here. When you look at the labs, you see a low fasting insulin in highly obese individuals sometimes. And then you're surprised and you see that their sugars are also a little off or borderline. And then it's like the other way around because, usually we see cases with a normal glucose with high fasting insulin. And here we see a a slightly higher glucose with low fasting insulin. And correct me if I'm wrong, but I think we could either attribute it to the leptin resistance, because I know leptin interferes with insulin secretion, or it could be the burning of the pancreas, in which case the C-peptide would be an ideal choice as a marker to test.
And insulin lasts in the bloodstream for just a few minutes. So you may not be exactly knowing the base tendency because it can fluctuate so much.
Right.
So you could do a baseline insulin and C-peptide and then a post-meal insulin and C-peptide to see if the pancreas is responding.
Interesting. Great. Coming to our next topic, which is really hot and happening, the weight loss drugs and the diabetes drugs. Are they making us hungrier and fatter?
Yes, some diabetes drugs do make us hungrier and fatter. I'll talk about 3 drug categories. One is sulfonylureas, then is glinides, and the TZDs, thiazolidinediones.
Right.
Okay. Clubbing sulfonylureas and glinides, because they work similarly, is these drugs go and knock on the pancreas and say, give more insulin.
Right.
The problem is it's not asking for insulin in the normal way that the body would have released insulin with its intelligence and with its glucose monitoring systems. These medicines go and lock themselves onto the insulin receptor for how many ever hours. So different drugs in that class have a 1 hour, 2 hour, 3 hour, different hours of action.
Right.
For as many hours that the medicine is attached to its receptor, it is asking for insulin release.
Right.
Okay. Now, irrespective of what the glucose is. So the glucose could be crashing low and the body is still releasing insulin because the medicine effect is still on.
Right.
So this is the person who's walking around at a buffet or a party saying, I need to be fed on time. I have diabetes. I need to get to the front of the queue. My sugar is dropping.
Got it.
They are the ones keeping biscuits and chocolates with them at all times or some juice because they're always worried that my sugar is going to drop. So this is a medicine causing this problem. It's not that people with diabetes are at risk of low glucose.
Right.
Our prescription is doing that to them. The side effects then become weight gain and hypoglycemia both. And the other one is the glitazones, which is pioglitazone mostly nowadays. We've stopped using rosiglitazone that much because of cardiac risk. Pioglitazone causes fluid retention and weight gain. It also causes bone loss. But from the weight gain and fatness perspective, yes, it is known too. So people who have heart failure because it causes fluid retention, they have to also be very careful on this drug.
Interesting. I'm currently managing a case of weight loss with a marginally high fasting insulin. This client is on Mounjaro and metformin. And when we began the diet, obviously we dived right into keto because he was ready for it. And usually I get a response of I'm too full, I'm not hungry anymore, I don't have these cravings. But in this case, after 6 weeks, I realized that he's still getting hungry. And it was a little unusual and I was trying to figure what can we do? And because as a doctor, I can't rewrite as a dietitian, I cannot rewrite a doctor's prescription. So I told him to check with his doctor if he could at least get the metformin out, right? And sure enough, he did that and his hunger went away. So now with the same amount of food, he was getting full. So the drug, in my opinion, was not giving him any added benefit in terms of the weight loss, but it was just making him hungrier.
I haven't seen that. I haven't seen that correlation of hunger with metformin. Sometimes there are gastric side effects, of course, with the GLP-1s like the Mounjaro or the GIP or metformin. You can have gastric side effects and almost like a nausea. But I think that's where it comes down to listening to each patient and seeing what works for them.
Right. I think what it does is also causes this pseudo hypoglycemia where they feel like the sugar's dropping, like you mentioned, and they're feeling hungry, but they're not actually hungry, or they don't really need food, but they are seeking food at that point.
So yeah, we should clarify that both metformin and the GLP-1 GIP class of drugs are not expected to cause hypoglycemia. But if somebody was used to a glucose in the high range, in the 200 range or 180 range, and now because of the keto diet, because of going low carb, because of the medicine, now they are at a 100 or a 120, even though that's not low,
Right.
they may be feeling low because the brain is sensing the glucose is crashing. That should settle. That should settle within a few weeks, where now this feels normal. And if you start going high, then you start feeling sick.
This particular case is not diabetes, right? It's just weight loss. So yeah, there is insulin resistance, but it's not frank diabetes.
Not frank diabetes. So then you have to actually help them correlate and be confident that it's not even high glucose, it's not low glucose.
Right.
It's you're learning to listen to your body signals and you're not at risk of a low glucose.
Right. Also, adding about type 1 diabetes, we do know that if we keep feeding them carbohydrates, we have to keep increasing the insulin dose. And then it brings us to this concept of double diabetes, where the exogenous insulin itself is causing insulin resistance, right? So we really need to educate people about what they're doing with these drugs, because it's just making them eat more and get fatter rather than what they were supposed to do or what they were prescribed for originally.
Absolutely. So that's the sort of sad messaging that goes to somebody with type 1 diabetes is, oh, you have to be on insulin injections anyway, so eat what you want and cover it with insulin.
Jab.
That's just not right, because you could give them insulin resistance if you're giving them more than what the normal body would have been exposed to. And so Dr. Bernstein came up with this concept of the law of small numbers. And the way I describe that is it's like being stuck in Mumbai traffic, where you're having a little bit of acceleration, then brake. So if by mistake you touch the car in front of you, the damage is like a slight dent, a little yelling, but no major danger. But Formula One racing, high speed, the accidents are much more dangerous. So when you're living a low carb lifestyle and type 1 diabetes, your insulin doses are low.
Right.
Your risk of very high or very low glucose is also low, because you're playing this, slow game. It's a small numbers game.
Right.
Versus high insulin, high carb lifestyle, very volatile. And the sad label then becomes this person has brittle diabetes.
Right.
There's no such thing as brittle type 1 diabetes. This is mismanaged, where we've not educated them on carbohydrate insulin management.
Right.
And high carb, high insulin, very volatile glucose.
Well, then it's pretty clear that, doctors and dietitians must communicate constantly with each other, which does not happen because in India, we really don't have a multidisciplinary approach to treating a condition. And you are a doctor, I'm a dietitian. You also, advocate the low carb way of living. You educate your patients through your courses and your books about nutrition. And you would definitely understand how important it is, especially if, the patient is on insulin or is taking, say, a SGLT2 inhibitor. And the sugars start dropping immediately in the first week because the diet has begun, but the doctor is not aware, and we have to keep telling them, hey, listen, you're touching 60s and your 70s in your glucose. Please talk to your doctor and get that one drug out, because I cannot stop the diet now, right? We're right in the middle of this. So it's so important for us to communicate so that the patient benefits.
Absolutely. And we should help each other out more. I'm realizing that I probably should be more available for these kind of situations. You're doing the right thing. And I think we need to help such people have the medical supervision for safety. They're actually treating the disease at the root, and then they don't need so much medication. That's the best case scenario.
Right. Our next topic is the cortisol belly. This word is viral on the internet, and I want you to share some wisdom, because it's the hormone cortisol and the hormone insulin that we're talking about. So please enlighten us.
Sure. So cortisol and insulin are both life-saving hormones. We need them. We would die without them. Okay. So all this discussion sometimes makes people scared of insulin, scared of cortisol. That's not right. The issue is chronic exposure to something, which means continuous long-term non-stop exposure to something, is when a system can break down.
Right.
If you drive a car with your foot non-stop on the accelerator, you're going to have a situation, right? You need to be able to give breaks in between hormonal exposure. Cortisol is a stress hormone. You do require it when you're in stress, whether it's a fight, flight, fright situation. Chronic cortisol is because now we have life stress.
right? We're not in physical danger most of the times, thankfully, for being listening to this podcast. But the chronicity of the way we live our life, or the stress that doesn't stop the next day,
keeps us constantly exposed to cortisol.
Right.
What does that do? Cortisol's job was to give you a burst of energy to run away from danger. It's going to throw some glucose into the system to help you escape out. Now, if you do that constantly, non-stop, then insulin's going to come and say, hey, this is high glucose now. We need to have high insulin in response. And even the insulin's not getting a break. High cortisol, high insulin. So now the chronic stress becomes a driver of insulin resistance,
Right.
which is what we've been talking about. And I talk about this in my book. It's one of the major drivers. It's one of the 4 wheels of the lifestyle car. Chronic stress can directly increase insulin resistance. That causes fat gain and weight retention around the belly. It's through insulin. It's not directly cortisol just by itself.
Interesting. So the molecule in question is glucose and its related hormone, which is insulin, driving this whole, cortisol belly terminology that we're using. Yes, cortisol does, affect the fat cells directly through its receptors, especially the visceral area. But I think what we need to address more in terms of, like you said, chronic stress, lifestyle management, and of course through the diet, because even if you do control your stress levels, but you just keep pushing more carbs into the diet, finally we're going to end up with a glucose belly.
Correct. That's why I talk about 4 wheels of the lifestyle car. Is you can have a puncture in any one of the wheels, and maybe today it's the nutrition wheel that's in trouble. Maybe you sort it out 6 months down the road, a major life stress hits you, and the stress wheel takes a hit. So life is like that. Life is dynamic. We don't live in perfect labs. It's a bit topsy-turvy, through the ups and downs. So having a framework helps us to keep relooking the situation. There's no sort of clean shit. And I think that's why we need to have long-term trusting relationships, build communities, have these conversations, right? So that you keep checking what's going on. It could always be some new information that you need to look at. That's right.
So we're almost coming into the last segment of our discussion today, and I'm going to discuss 3 states, hormonal states, in which a low-carb approach can be used, but there is a lot of myth surrounding it. So the first one I'm going to talk about is PCOS. What's your take on keto or low carb for PCOS?
It's extremely helpful. I'm actually speaking next month at a gynecology meeting on recurrent pregnancy loss. And PCOS is one of the major drivers of miscarriage, recurrent pregnancy loss, reduced fertility. And there are so many papers talking about achieving a healthy body through reversing insulin resistance, metabolic syndrome, to address the PCOS and how that then translates into better pregnancy outcomes. So for sure, low carb is safe, and I use it all the time in my women. I've had them surprisingly just get pregnant because initially the PCOS was causing irregular periods. So they thought, oh, I'm not conceiving. And then they've conceived and they're not getting periods, and they don't even realize because they were focusing on low carb, and they actually conceived spontaneously.
Nice. And adding to that, I would say in my practice, I have seen a drastic reduction in the fasting insulin levels, although these women were on drugs pre and post. But when we check, the insulin levels drop when the diet begins. That automatically translates into better metabolic health, because we know insulin resistance is the core dysfunction in PCOS.
Yes, and that applies to lean women who have PCOS as well as the overweight. So someone who's lean might say, but how can I have insulin resistance? I'm not overweight.
Right.
But we talked about the skinny fat or the visceral fat. So even within PCOS, any body type, insulin resistance is the major driver.
Talking about fertility and pregnancy, so I want to discuss this one case in which the lady had come to me with 3 failed IVFs, and she was fairly overweight. And then we decided that we're going to give a window of recovery for her body to be able to bear a child, right? So we began with the low carb diet, and she had taken a decision not to be pregnant in that window. But you know how it is when your body is ready, and she naturally conceived. And I'm not the one to say that you should not proceed with the pregnancy, right? So we decided that yes, we're going to take it forward. Now, coming to the second part, during pregnancy, I have this case in which there is a history of being overweight, a miscarriage, infertility, also it improving once the diet started. Now we're in the middle of the pregnancy, and now we're sitting with gestational diabetes. So here we take a call that obviously the scans were being done at regular intervals and she was doing very well. And you would also be aware that there is a cutoff for the weight gain per week for pregnant women who are overweight. So we decided to continue with the low carb approach, and keep monitoring her. And she sailed beautifully through the pregnancy, had a normal child, a normal delivery, and no requirement of insulin through the entire pregnancy. So I know that the books really don't talk so much about it, but you being a doctor and a medical professional, I want your take on it.
Yes, it's really sad. You're right that it's amazing news for your patient, but it's sad that the guidelines, the books don't address this, even though it's a very obvious connection. And I'm part of a medical community, a global medical community of experts, where I see gynecologists, obstetricians using low carb with great success in their women.
Wow.
And so it's high time that we look at this more carefully, because women and doctors are having to go against the mainstream advice of fill the plate with carbs. And healthy weight management, healthy insulin levels gives a healthy baby and actually reprograms that baby to have less risk of diabetes in themselves 25-30 years down the road.
I believe that pregnancy itself is a natural state of insulin resistance at some point.
Yes, it is. So you want to manage that and not have it reach pathology levels where the glucose is now high, the mother's high insulin is getting into the baby's body, and you have overweight large babies that need C-sections, difficult deliveries. But luckily, when you make the diet changes, you can actually calm that system down, lower and normalize the insulin. Even with the insulin resistance, you can achieve the normal glucose levels for the mother and baby.
Wonderful. Coming to the topic of hypothyroidism, right? We see a lot of these cases now in India, especially when it comes along with the perimenopausal transition and the menopausal transition, where we see that the TSH levels start going up because maybe it has a correlation with the estrogen. But you and I have discussed that hormones don't work in isolation. There's a crosstalk across all hormones. They are continuously in sync, right? And what's your take on advocating a low carb diet for hypothyroidism?
Yeah, like you reminded me of my quote. I think low carb works for anybody with 2 hands and 2 feet. It definitely works for people with hypothyroidism. I am a remission case of Hashimoto's sitting in front of you. I used to be on 100 micrograms and now my dose is 0 for the last decade or so, more than a decade. And the TSH is pretty stable. It sometimes will fluctuate into the 5 range, but I have never needed to take any medicine. People would look at me and say, you don't look hypothyroid, because they have this conditioning that weight struggles come with hypothyroidism. That's not true. We have to bring it back to insulin resistance. So yes, I recommend low carb for somebody. Oftentimes when someone with a thyroid diagnosis comes in, they think their weight is because of their thyroid. And I'm like, your weight is because of your hormones, but it's your insulin hormone we have to talk about. Thyroid is not to blame. And I should add one myth that we need to bust here is when I go low carb with my patients of hypothyroidism, inevitably we're telling them take more vegetables, more protein. And in vegetarians, this means a soy or a tofu or a cabbage, cauliflower, broccoli. And there are myths out there about myths about people with hypothyroidism needing to avoid this. Not true. I consume these foods regularly. I prescribe low carb, including these foods regularly. And very often I'm able to actually reduce the need for thyroid medication, keeping an eye on the TSH.
Interesting. So it's insulin everywhere. And that's why we're having this discussion. I want to actually finish the segment with one case of Hashimoto's along with PCOS and type 1 diabetes. And this girl came to me when she was 25 years of age and she wanted to conceive. And, I put her on the ketogenic diet because whenever I have these discussions with my clients, obviously I require the consent and the willingness to be on a diet like this. And it worked really beautifully in her case too. So 3 conditions that we just talked about existing in one person.
So that's a sign that you're on the right track, right? Because if something is good for the body, it's good for the body. Full stop. It doesn't matter. It should actually be something that addresses all 3. And I see that in a different way is I'm an endocrinologist, but someone may come for not just weight or diabetes. They'll come with joint pains, insomnia, lot of PMS, lot of inflammation, other things that gut symptoms, bad digestion. I'm not directly chasing those, but when we address insulin resistance, guess what? So many of those conditions get
Fall
better.
into place.
Yes, fatty liver gets better, blood pressure gets better, triglycerides get better. If you're doing the right thing, the body's intelligent enough to use those good habits to fix so many other problems.
Lipid profile gets better, sleep gets better, exercise performance gets better,
Skin gets
better. This brings us to the end of this insightful conversation. Thank you, Dr. Roshani, for coming back and sharing your expertise with us. It's always a pleasure to learn from you.
Thanks for having me.
And to our listeners, thank you for tuning in. If you enjoyed this discussion, share it with someone. Don't forget to subscribe to the channel for more insightful conversations like this. Until next time, this is Shwetha Bhatia saying bye with Dr. Roshani.